My name is Scott Montgomery, OSCA's Executive Director. And it's a great honour to have you again here for our second week of OSCA Live. And it's great to have with us Dr. Miles Beeny. So welcome, Doctor. I'm going to call you Miles for the evening. Is that okay?
Please, yes, of course. And thank you, Scott.
So Miles is an old boy from the school, from the class of 1995. He's also a current parent at Scotch College with two boys in the junior school in grade 2 and in grade 5, I believe. So he's the senior ICU medical practitioner at the Peter MacCallum Cancer Centre, which is supporting the efforts of the Royal Melbourne Hospital during this COVID-19 pandemic. So it's terrific to have him here, and thank you very much for coming. I just put a bit of a backdrop as to where we are in this beautiful surrounds of the Sir Zelman Cowen Centre for Science, a building that's been open for a couple of years now, and it's just it's a great forum to host these types of chats.
A very appropriate venue, yeah.
Yeah, it certainly is. So do sit back, and now I hope to take you behind the scenes of Miles's world. It's certainly a world that fascinates many of us, and hopefully you get a bit of an enjoyment out of the next half hour or so. So before we get into the medical side and your world within the health organisations, a little bird told me that you played the violin back in '95, and that you had a little excursion overseas to Europe.
Yes.
So do you still play the violin, and how's that helped you, post school?
I unfortunately don't play anymore.
Oh, that's going to upset some people, I think.
I know. It's helped me in a number of ways. I played when I left school and went to university. I joined the university orchestra, and then when I went to clinical years. So medical school is divided into pre-clinical time and then clinical time in the hospitals. It was just difficult to maintain the connection with the orchestra, and then not having an orchestral connection and moving around between hospitals as junior doctors do, it just sort of fell by the wayside a little bit. What I would say that it's helped me with, though, is it's given me an appreciation for music that I've never lost. And I'm rediscovering again a little bit now as our children are taking up their own instruments. Unfortunately, they're both playing double bass, which of course has different intervals between the strings than a violin, which means that all my instincts when I'm trying to help the boys are completely wrong. It's very unhelpful, that. But at least I've got an idea about strings and can help them a little bit. But I think once you've played in a decent orchestra, and the Scotch Orchestra was and still is, I think, a decent orchestra, you get an appreciation that makes listening to music a much more enjoyable experience. You get an appreciation that you wouldn't otherwise have.
Yeah,
that's lasted.
The music facilities here and the music that they pump out is with the Foundation Day concert. It's amazing. So, so let's get into the world of a medic. So, what does a senior medical practitioner do, and what does your day look like? Take us into the scenes.
Yeah. So this is my days are very varied, and they've changed a lot since I moved into the role of trying to set up the intensive care unit at Peter Mac. Before then, I was predominantly in private practice. I was part-time at Peter Mac and part-time in private. And so I did a lot of clinical work, so principally looking after patients. But more recently, I've been doing a lot more administrative work and even some assisting engineering works. So we had to look at our floor plan, look at how things were ducted, and try and work out where we could place beds and things like that. So I did a lot of meetings with engineers and the building, the plant managers for the building. I had to spend a lot of time liaising with the representatives of the junior medical staff to discuss how we were going to roll out education for them should they be needed in the intensive care unit, and also with our nursing staff. So that was that they have intensive care is very nursing oriented, and so their input was pretty important in the planning stages of this as well. So there was a senior nursing officer as well who was part of the team. Mm. These days, now that sort of frantic stage is sort of fading a little bit, I divide my time between clinical responsibilities at Peter Mac, which includes sometimes giving anaesthetics and sometimes looking after our critical care area, and also continuing to ensure that all of those plans are still being proper. There's still a lot of wrinkles, all these tiny little details that when the devices are arriving, there's questions about how are they going to be integrated in the current system, the programming for them with the different drug recipes inside the pumps for.
Where's that equipment coming from? Where's it?
There's two main streams. The hospital's ordering some itself, and that's sometimes difficult to arrange because it all comes down to finances, which I try to offload onto executive people as much as possible. So I say, this is my preference about what we should be doing, but these are the options. I think this is the best one, but sometimes it comes down to simply what we can get, though, because we are competing with not just other hospitals, but other hospitals around the world for equipment. In particular, I was a bit concerned that we might not get access to ventilators quickly enough, so we were having to make some plans in case we didn't get them, about how we would deal with the situation without formal ventilators. And we had a backup plan that I think would work. Yeah. So, and I've taken on a little bit of time at the Royal Melbourne, because Royal Melbourne and Peter Mac are right over the road from each other with a physical connection between the buildings. We can move patients between them. So I've been spending time liaising with the ICU there, and even doing some shifts as an intensivist at Royal Melbourne occasionally to maintain that link.
There was some really graphic footage from overseas, particularly when the Italian hospitals and the European scene was really going bad. A lot of overcrowded corridors and bits and pieces like that. So that really shocked me to watch. Did it shock the health fraternity? Was it a shock to you? Did it come as a surprise to you, or were you ahead of the game, or what were you expecting? And sort of how did that feel to you and your colleagues?
I think, Scott, that came as a surprise to everyone. It was particularly surprising that part of Italy, which is not just a wealthy country, but a very wealthy section of Italy. It's one of the wealthiest regions in Europe. Very well set up, very well resourced hospitals were so overwhelmed so quickly. And I think it told us that there was the possibility that this virus was sort of circulating in communities and wouldn't be obvious and detected by us in the medical profession until it reached a point where maybe it was too late and that escalation was already happening. Their first intensive care patient happened, and then within a week they were suddenly full, and then a week later they were overflowing with patients they couldn't manage. So it was a scary vision, definitely, and it gave me quite a few sleepless nights, I certainly don't mind admitting.
Yeah.
But the Italian experience certainly informed us too, because they were the ones who were able to then give us information. We communicated directly with them. They made podcasts and sent emails around. What was one of the interesting things about the early phases of the global response to this was how much informal communication became really important between hospitals internationally. So we were talking to people in the UK and America and Italy, and just sharing information as much as we could. And it was all very much not in the style of how medicine is usually communicated. You know, this long period of time where people submit manuscripts for consideration for peer review and then get published in a journal, and then it takes a long time for a new idea to be sort of tested and examined and then put forward. But with this, we knew there wasn't time for that, so it was a very different approach.
I've got a vaccine question coming up, but so what has surprised you most about setting up the ICU unit, and what's something that you're really most proud of?
One of the things that surprised me was, I think the thing that surprised me the most was how much some people in, I've got to be diplomatic, I suppose, it's still very important how much everything costs. And I suppose from a naive point of view, which I had going in, I thought, look at the huge sacrifices that are being made. There's a vast economic cost. The amount that we want to spend on a bit of equipment is tiny compared to the amount of money that the Australian government is spending on this. Surely this is going to be easy to get funding for everything that I want. And that wasn't quite the case.
Not right.
But what I was most proud of, I think, was the response that I got from staff at every level. Nursing staff, junior medical staff, medical students, my senior medical colleagues. It was really impressive how we had 50 nurses who had some kind of experience in intensive care, who were working in other roles at Peter Mac, who immediately volunteered to go and start doing some shifts at Royal Melbourne to be upskilled so that they could be ready to help staff the unit. I got peppered with emails from the junior medical staff saying, how can we get training? How can we help? And a lot of my senior colleagues were deeply, deeply involved in planning how we were going to manage various. It was really impressive how different ones of them would take on a different aspect of what we were going to do, a small technical detail that needed to be worked out and thoroughly thought about, and would solve that problem and come back and present it to the rest of the group. And it was a real coming together, so everyone was working very hard and very enthusiastically to deal with this common threat.
Yeah. And my wife, my sister, and my mum are all nurses, and I know what a wonderful job they do to help doctors and everything. So where does the nurses, with all their knowledge and expertise, fit into the planning and the implementation of these special, facilities that you work in? So,
as I alluded to earlier, nursing in intensive care is critical. Pardon the pun. The basic model of intensive care is one nurse to each patient. For high dependency units, it's one nurse to two patients, but that's a lot of nurses that you need who are extremely well trained and skilled. And one of the key things that we were addressing as a potential problem, which they had to address it overseas, was the lack of enough intensive care nurses to staff all of these beds that we were putting together. Yeah. So we were coming up with plans to try and assist nurses who would volunteer from other backgrounds and have enough intensive care nurses spaced between them so that they could provide a leavening of a higher skill level. It did get particularly bad, I think, in the UK. I read an article in which someone mentioned that NHS employees at all levels were being moved into intensive care. Dental hygienists working in bedside roles in intensive care units there, just because of at the peak of their crisis, how many patients they needed. And these weren't simple patients to manage. It wasn't simply a question of put them on a ventilator and wait for a few days and they get better. There was a lot of work involved in looking after these quite complicated intensive care patients. Yeah. So huge role in nursing for education and for preparation. And as I said, there was a senior nurse involvement in the planning stages at every moment. There's no way I could conceive of trying to do this without extremely heavy involvement at highest level from nursing staff.
Yeah, that's good. We spoke about the vaccine before, and there's obviously a global race to get this vaccine. And I think the media's dropped off a little bit. There was a real fascination of how this was being developed around the globe, and how all the medical fraternities are getting together. I don't even know how they share knowledge and the progression they're making with that. So what is the likelihood, in your opinion, of a vaccine? How quick are we going to get it, and how quickly are we going to actually see it available for GPs to administer?
So first of all, I'm not an immunologist, so I'm not an expert in vaccine development or management of them, but I do think so. There's a couple of things to put out there. One is it's a coronavirus, which is one of a family of viruses. There's no vaccines for any other coronaviruses so far. Most of them don't cause much in the way of serious disease, though. There's only been a couple of serious diseases caused by coronaviruses, and everyone will be familiar with SARS and MERS, which were two previous related diseases to this one. I think the crucial thing, people started working on vaccines for both of those things, particularly SARS, but both of them sort of fizzled out. And so the incentive to keep plugging away at building this vaccine was lost. There's no longer an economic or a medical imperative to get one. And so people moved on to more immediately pressing areas of research. There's not infinite amounts of funding for medical research, so moved away. I am therefore hopeful that there is at least a chance that a vaccine will work for this disease. Early indications are that people seem to develop at least some level of ongoing immunity. How long that lasts is unclear, but even a vaccine that has to be administered every year would be a huge improvement. It makes a big difference with influenza, for example. So if we had something like that, that would be fantastic. I think it's possible. I even think it's, as I said, I'm not an immunologist, but I do think it's relatively likely that we will get at some point a vaccine. The other half of your question was how long will it take? And precisely, how long is a piece of string? Maybe a little bit shorter than usual, because hopefully people can work off the research they've done for the SARS, the original SARS vaccine that everyone, a lot of people were working on back in 2004. And so there's a sort of a piggybacking of research there. Plus, there's a massive economic incentive to get one. So if you throw enough money at things, amazing things can happen.
Where do you think it's likely to come from? From Australia or from America or from Europe, or a combination?
I think it's got to be a global effort, and something like this, you've got to test so many different sort of possibilities and push all of them, because you want to develop it soon. You need to actively work on lots of possibilities all at once. So it could come from anywhere. Certainly it could come from Australia. Australia has an extremely good record in vaccine development and science in general. You'd have to say that victory usually goes to the big guns. So the Americans have a lot more resources to throw at this, even with ambivalence in their structure. The Chinese could come up with something too. They've got a lot of resources and they're doing a lot of work too. So I wouldn't be surprised if they came up with some sort of breakthrough too. And of course, there's plenty of people working in Europe very hard on this too.
Yeah. How do they work together? I mean,
I think they work in parallel, but I'm not a researcher. You probably need to.
Yeah. That's quite a fascinating topic in itself, isn't it? Do you think Australia's prepared for a potential second wave?
That's what we're doing now.
Yeah.
So most of what I'm doing now is on the assumption that we've got time, and thanks to the incredible job that Australians have done in shutting down and preventing the transmission of this virus, we've got hopefully a fair bit of time to prepare for a potential second wave, which would hopefully be not nearly as bad. Is there a possibility we could eradicate it and not have to worry about that? I suppose it's faintly possible, but I think it's an unlikely hope that we couldn't get some kind of resurgence. And then I think most of us in the profession, at any rate, think that there'll be some sort of easing on and off again. And my hope is that with really rapid and focused contact tracing, people will be able to shut down areas before they become a hotspot for infections and spread widely.
We'll come back to that COVID ad, the app that I have. I know we'll finish with that one, but I wanted to progress with, there's a view that kids can't get COVID and they can't be a carrier. Can you dispel that or?
Obviously, we are in still early days of understanding exactly what this virus does. But consistently in the early reports from China, from Italy, from America, there were not significant numbers of children testing positive for one and getting sick for two. So most of the children who were found to have the virus and were tested positive were shown to have contracted it from adults in their own household rather than from other children. So there does seem to be a degree of resistance to catching the virus in the first place amongst children. And the number of critically unwell children, particularly young children, has been minuscule, which I find personally extremely reassuring. It's, I think, changed the way that we might have viewed this. If it had been something that affected children a great deal, I'm sure that I would have had to approach this very differently with children of my own. It would have been a much more worrying situation.
What about this? People say you can be a carrier, but you show no symptoms at all.
That's certainly true. We know that people virtually everyone who catches the coronavirus will go through a phase where they are asymptomatic, but actively shedding some of the virus. That was one of the big differences between this virus and the SARS virus. The SARS was only really spread when it was in people who had florid symptoms, but this one seems to be able to spread from people who have no symptoms at all.
So you can go through and have no symptoms and have had it and lose it, and then...
That certainly seems to be the case. Yes, a sizable proportion of people, and it depends which group, which study you look at. And again, early days, but maybe 10 or 20% of people who have it never even seem to get a cold that they notice.
Yeah, right.
But they can spread it, and it can go to vulnerable people from them.
Which is the worry.
Exactly.
Yeah. So given the huge economic cost, and that's an understatement.
Yes.
But here in Victoria, we've had less than around 10 in ICU. So we're obviously doing some good things through the work that you're doing. So have we got it wrong?
Take credit for that. That's the Victorian people.
So obviously we're doing something right. The Victorian government and the national government, the federal government, doing a pretty good job, I would have thought, in terms of containing. It was all about flattening the curve and doing those things.
We did that extremely successfully.
That's on now page 5 of the Herald Sun rather than page 1. So it's sort of drifting off. That's
clearly a good sign. I think we're going to be able to look back in the future and look at the way different countries approach this, and people will point to say that this country clearly did the best job in muddling through with it, the minimum economic cost and the minimum deaths, but trying to work out the absolute best path in the face of a massive public health crisis is a very fraught thing to do. And I think the government chose a pathway which they decided was the best one, and they stuck to it. And to their credit, it seems to have worked very well. Certainly, the fact that we didn't have, one of the macabre aspects of planning for this was how would we deal with a situation like they had in Italy, where they didn't have room for the bodies in the hospital morgues. So we had plans for refrigeration trucks for outside the hospital if that reached that stage. And I'm extremely glad that I'm not having to activate that aspect of the plan.
Yeah, but they were seriously part of it.
It was part of it.
Jeff Shedd was part of it. All those types of things.
That's right.
Facilities that were being geared up to be hospitals and house beds. And that was
Jeff Shedd, I think it was touch and go whether it was going to be a hospital or an emergency morgue.
Emergency morgue.
That was one of the other considerations.
Wow. Okay. Do you think we've gone too early with elective surgery?
I think there's a misconception out there what elective surgery means. So elective doesn't mean things that are unimportant. At Peter Mac, we do mainly elective surgery. Almost all of the surgery done at Peter Mac is elective surgery under the classification that we use, and it's not stuff that you want to delay if you can avoid it. It's life-saving removal of tumours. A lot of it is time critical as well, but because it's not, it must be done now or the person will die or lose a limb, that means it's not an emergency. So there's different categories of elective surgery. Personally, I think the government's doing a reasonable job of staging that and saying category ones, which are things like time critical tumour operations or heart operations that are potentially life-saving, are allowed. Important category twos, which are things that will deteriorate if left longer than a certain period of time, they were allowed, and things that were non-time critical were not permitted. They're letting us do a smaller amount of those non-time critical operations now, and I think it's about right. We'll have to see. If there's outbreaks in hospitals, then we'll have to cut back. I'm hopeful that won't happen. I think, especially with the improved precautions that everyone's taking in theatres, on the wards, there's been a cultural change in the way infection prevention is approached in hospitals as a result of this. And I actually think it'll have some other benefits too. We'll probably see reduction in hospital-acquired infections just across the board as a result of the change this is causing.
I've got a little prop here from my visit to the GP yesterday, and no, I don't have it. There's been a lot of conjecture about face masks and things like that. So, and adults actually wearing them, and should we be wearing them, positives and negatives, and how you actually put it on the right way is another one.
So with that mask there, you wear it with the blue side out.
Thank you for that.
The question of masks is a good one. Increasingly, it seems clear that wearing masks can cut down transmission. It's probably because it means that people who got it, if they're wearing a mask, are less likely to spread it, rather than necessarily protecting the person who's wearing the mask, although it probably has some protective benefits as well. In hospital, it's a bit different when you know that you're going to be exposed, and wearing the appropriate protective equipment does and can protect you, and we've got good evidence for that.
Do you wear those big bubble things?
Some of my colleagues have taken to wearing them in theatre. It's overkill, and there's not a good evidence that it
what about
makes
the patient? They stick one on his head.
Oh, you've seen that they were doing those in Italy. The CPAP helmets and things like that. Those are also for ventilation and to give high oxygen.
You got one of those?
No, we don't. We don't. We don't. They're very Italian. Those
could be good
space
party out there.
It could. They use them in hyperbaric medicine in Victoria, so there are some around. Probably get some at the Alfred. But going back to the question of masks, I think at the moment, with the relatively low community transmission, it's probably not worthwhile to get everyone to wear masks. It will deplete the stockpile. But if there's an increase, as at some point, I think there probably will be, if there's an increase in that community transmission, then it may become advisable for people to wear masks. Certainly, I think in countries where they've got far more cases and far much more transmission going on, I think it's highly advisable. Yeah. If I was in America, I would wear a mask and encourage my family to wear masks.
Yeah, that's good advice. So how are physicians coping and dealing with their own mental health? Have you obviously had peaks and lows of your own anxiety, I would have thought, and that's something natural. So,
especially in the early phases of this, it was very, very worrying. So I was, anxious.
Understandably.
I think everyone copes differently with stress. Personally, I tried to speak with my wife and reassure her, and in reassuring her, I reassured myself.
Yeah.
I listened to music, and I tried to read more fiction, which allowed me to escape the concerns of this reality for other fake concerns for a little while.
I think we've all had our own little tricks as to how we can escape these things. I've got into walking which is something I would never have done. And listening to the odd podcast. So
Podcasts are great.
Yeah. So even surprised myself. Just a couple of quick questions to go. So I know there's one person who's watching us here who doesn't have this on her phone. Is the COVID app. I think it's a terrific thing. It's pretty simple to do. So I think we should plug that and your thoughts on that, and encouraging people to put the COVID app on their phones. And I was only reading this morning that there was a case that the COVID app actually assisted them tracing, to that. And I think it was to the meat factory or whatever, but the COVID app does help. And I think we should be encouraging everyone to put it on.
I think it will make contact tracing easier for when there are more cases detected. If you have this as another tool in the contact tracers armory, because at the moment they have to rely on basically interviewing people. It's very labor intensive the way they trace contacts. Spend a long time asking someone everywhere they've been, everyone they've interacted with. Then you go and talk to all of those people and test them, see if they've. So it's very labor intensive, very hard work, and potentially misses people. Is the COVID app going to be a perfect way of contact tracing? Of course it can't be. There'll be false positives thrown up by people who were passing by on the other side of a wall or something like that. But it's a lot better than nothing. When I first read about it, I did have some faint privacy concerns about it, but I read a great deal about how it works, and I'm relatively reassured about that. I'm not too concerned that, in fact, I'm fairly confident that they can't track where I've been and what I've done based on this app. It seems to me to be pretty secure. I'm not a cybersecurity expert, I hasten to add, but to me it seems like a very easy way that we can all help and keep. If we can control outbreaks, then we can have the economy open up even more, get back into a more normal way of living, which would be fantastic.
I just think that's the point, is that it's such a simple, easy thing to do. You have Bluetooth on the time. Our kids are on these apps and everything. It just should be a no-brainer. But anyway, can someone get my son to put it on? So anyway, I'm working on it. Just a final quick one for me, Miles, is schools are opening next week, which is joy to everyone. So year 11s and 12. I got
with one or two exceptions, William and Edward. But
yes, your kids are quite happy at home. But so what advice would you just give to the parents and community, next week as the hustle and bustle begins again?
As we talked before, kids do seem to be relatively resistant to infection by this, and they don't seem to spread it. I do know that there have been some concerning reports coming out in Italy and America about the possibility of some post-COVID syndrome appearing in a very small number of children. It's very early, and it's really very difficult to say that it's directly related at all. It's such a small number, and really, I'm personally not concerned. I'm sending my children back to school, despite their wails of wails.
Mr. Abbott's looking forward to having them.
Yeah, I hope so, but I think once they get there, they'll be fine. I think what actually is more important about transmission around schools is not the children, it's the adults. So parents congregating closely, and it's going to be very hard. I'm sure there's a lot of people who've missed friends that they've made over the years at school drop-off who they're very keen to see again. But I think the school needs to be careful about how they handle that drop-off process, so that those of us who are vulnerable and can catch it very easily and can spread it very easily aren't exposed to each other more than is necessary.
Drop and go.
Yeah, exactly.
Yeah, drop and let them walk.
And not have too many people in the staff room at the same time. I suppose that's the other thing.
Oh, I think that's very sound advice and comforting, I think. And
it is very reassuring to look how,
particularly working at the school, it's just a void without the boys being around here. And so I'm looking forward to seeing them all back next week. And so Miles, thank you very much for coming in at short notice, I know, but
thank you, Scott.
It's been enlightening. So the pleasure of our appreciation. I'd just like to give you a little gift from our friends down at up at Rutherglen, a lovely bottle of little musket, little sweet number for after
very kind.
And the OSCA centenary tie. Not that we're really into ties these days, but if you do need to wear one.
I do sometimes.
I would shake your hand, but we'll just do one of those. And thank you again for coming.
Thank
so
you,
that
Scott.
wraps up OSCA Live number 2.
Thank you.
Miles, thanks again for coming. It's been a pleasure to host you all this evening. And stay tuned for next week, where I will be having a chat to the chairman of the school council here, Dr. David Kemp, and the OSCA president, James Douglas. So stay tuned for that one. Thanks again. Keep active, keep safe, and thank you and good night.
Good night.